Hello and welcome back to our didactic series on emergency department crowding. This is Module 3, Solutions to Crowding. I'm Brian Franklin. I have the privilege of working with Eric Goralnik on these modules. Special thanks to Shen from Stanford for taking the time to share his firsthand insights from implementation of an inpatient hallway boarding program. We'll discuss that later in this module. This is Module 3 in a three-part series on ED crowding. In Module 1, we defined ED crowding and examined its impact. In Module 2, we discussed the drivers of ED crowding. And in this module, we'll explore countermeasures to each of these drivers. Today, we'll provide a non-exhaustive overview of countermeasures to crowding. We'll also explore several of those countermeasures in depth. Just like in Module 2, where we explored causes of crowding, this module is organized around the classic input, throughput, output conceptual model of ED crowding. We'll take a look at countermeasures designed to address causes of crowding in each of those categories. We'll also explore solutions to drivers of crowding related to hospital-wide, operational, and economic factors. Let's start by looking at interventions related to input factors. So in Module 2, we discussed how many ED visits could ideally be addressed at sites other than the emergency department. To address preventable ED visits, we can increase access to primary care or urgent care. Over time, consistent primary care can prevent certain acute conditions from developing in the first place. And when acute conditions do arise, if patients have timely access to their primary care offices, they can address those conditions there. Health systems can also create clinical pathways for ambulatory providers to escalate care to non-ED sites for common acute conditions within defined parameters. For example, cellulitis patients who have stable vital signs and maybe only require one dose of IV antibiotics and serial exams could have pathways developed to send them to sites other than the emergency department to have those needs addressed. Next, we'll review interventions related to throughput factors. As we discussed in Module 2, throughput factors are those that relate to ED care processes from the time a patient arrives in the emergency department until their disposition is determined. ED staffing affects all of these processes, so to the extent understaffing is prolonging ED throughput, then addressing staffing will alleviate crowding. If ED throughput is being prolonged by excessive time from the time tests are ordered until they result, there are a variety of countermeasures listed here, from implementing point-of-care testing to locating satellite labs in the ED to reducing the number of labs and studies ordered in the first place by eliminating unnecessary tests. Finally, improving what's called front-end operations can help reduce the time from arrival to provider evaluation. Let's take a closer look at front-end operations, and in particular, we'll take a look at provider in triage. So-called front-end operations are the processes that occur from the time a patient arrives in the ED until the time they're evaluated by a provider. We've listed 4 specific interventions related to streamlining front-end processes here. First, immediate bedding. So immediate bedding bypasses the traditional nurse triage step. If beds are available when a patient walks in and the patient can be seen right away, then there's no need to spend extra time up front triaging them, which really only serves to increase their ED length of stay. Instead, the patient can be roomed immediately with a nursing assessment provided by their primary nurse. Advanced triage protocols can be written to equip triage nurses with the ability to order certain labs and studies up front, and then by the time the patient is evaluated by a provider, results of those labs and studies ideally would be available, which reduces ED length of stay. Third, you can place a physician or other provider at triage to reduce the time from arrival to provider evaluation. This allows labs and studies to be ordered at the time of presentation rather than waiting to order those tests until the primary provider evaluation. And finally, a variety of studies have reported that dedicated fast-track areas have accelerated throughput times for low acuity patients. And the thought is that dedicated fast-track areas with their own personnel prevent higher acuity patients from displacing lower acuity patients in priority, thus allowing those lower acuity patients to be rapidly treated and discharged. Now let's take a closer look at provider in triage. So this is an excerpt from a conceptual article on provider and triage that tries to explain why provider and triage seems to have reduced ED length of stay in some EDs, but not others. So provider and triage works through two main mechanisms. First, placing a provider in triage allows you to order labs and studies earlier, meaning you'll reduce the time from patient arrival until their tests have resulted. Now, this can reduce ED lengths of stay, but it might not, depending on the local context. These two red icons depict two reasons why reducing time from arrival to resulted tests might not reduce ED length of stay. So first, when we look at this icon, we see it says testing must be on the critical path to affect ED length of stay. Let's zoom in on that one and see what that means. So the critical path is a sequence of events determining the minimum amount of time needed to complete the entire project. And here our project is patient arrival in the ED until patient disposition. And the critical path is depicted in red. Let's say we place a provider in triage, and now we get the patient's tests ordered, say, 15 minutes after they arrive instead of 45 minutes after they arrive. So now the tests are going to be ordered at 12:15 instead of 12:45. It'll still take 30 minutes for those tests to get back, and we'll get those results back at 12:45 instead of 1:15, which was the original situation without a provider in triage. That's great, right? Well, sort of. The problem is it's going to take at least 90 minutes in this hypothetical scenario from the time we request a consult until the time that the consultant looks at those results anyway. So it's going to be 2:15 before the consultant looks at the results of these tests. So it doesn't really matter whether we get those tests back at 1:15 versus 12:45. Either way, this is the critical path. The consultant's going to evaluate the results, and then the patient is still going to be dispositioned at 3 p.m., no matter how early those tests result. So with this provider and triage intervention, in this particular scenario, we made no difference in how long the patient spent in the ED, and therefore made no difference in ED crowding. Next, we see that accelerating ED workup does not change underlying inpatient capacity constraints. So let's take a closer look at what that one means. So here, let's assume we are admitting a patient. In blue, we see a scenario with no provider in triage. The patient arrives to the ED at noon, takes us until about 2:15 to determine they're going to be admitted. In green, our thought experiment is now we're going to implement provider and triage. We order that patient's labs and studies right at triage so we get the results back earlier, and we determine the patient needs to be admitted around 1:45 p.m., which is half an hour earlier than the 2:15 p.m. dispo determination above. The problem is that we're facing access block. Either way, the next bed upstairs isn't going to be available until 4 p.m. So getting those tests ordered earlier didn't reduce the patient's total ED length of stay and therefore didn't improve ED crowding. Okay, now let's look at the other mechanism by which provider and triage can reduce ED length of stay, which is directly dispositioning patients from triage. So if a provider at triage can actually treat and discharge simple patients right then and there at triage, that should definitely reduce their ED length of stay, right? Well, maybe. If that emergency department already has a fast track area where patients can routinely be seen right away by the fast track provider, then having a second provider at triage probably won't reduce ED length of stay much. And in the literature, there is some evidence to suggest that this is the case. If you already have a well-functioning fast track, then adding a provider in triage who can directly disposition patients from triage won't make much of a difference in length of stay. So overall, provider and triage might work to reduce ED crowding, but this goes back to a point that we continue to make, which is that you really need to identify and quantify the root causes of ED crowding at your site before you identify solutions. So if your emergency department has a very high admission rate and most of your admitted patients are forced to board in the ED because your hospital consistently has inpatient capacity constraints, then placing a provider in triage might not actually be very helpful in reducing average ED length of stay, and therefore may not be a very effective intervention to reduce ED crowding. And one final point on provider in triage is that even if you won't make much of a dent in crowding at your site, there may be other benefits that justify the use of provider in triage. Now let's turn our attention to interventions related to output factors. As we discussed in Module 2, once you determine a patient's disposition and try to send them on their way, that's when you're talking about output factors. So if your ED is facing crowding because you're having trouble getting patients out of the ED, two categories of interventions are admitting fewer patients to the hospital and, when they do need to be admitted, getting them upstairs more quickly. In terms of admitting fewer patients, you can make sure it's easy to arrange outpatient follow-up so that people who can go home do get to go home and they don't get admitted just because it's too hard to get follow-up. In a multi-hospital system, you can make sure the right patients are admitted to the right hospital. So the Quaternary Academic Center doesn't use its limited inpatient beds on patients who could be served just as well in community facilities. You can implement ED observation units, and then finally you can try to compare admission rates apples to apples among providers and identify and address whatever is driving variation in those admit rates. The other category of intervention relates to reducing ED boarding, or in other words, figuring out how to get patients upstairs faster. One thing you can do is just move patients who are boarded in ED hallways upstairs to inpatient hallways, and we're going to take a look at that in depth in a moment. Another category of interventions has to do with reducing inpatient length of stay, and let's take a look at this in more depth with a specific intervention, the Discharge Lounge. So with the Discharge Lounge, the problem that we're trying to solve is that it often takes a long time from the point a patient's discharge orders are written until the time they physically leave their bed. And in this case, we're talking about inpatients. So a classic example is the inpatient who gets discharged early in the afternoon, but no one in their family can pick them up until after work, so they end up sitting in that room and taking up that bed for several hours waiting for a ride. In this case, you can see the patient is discharged around 2 p.m., but their family isn't able to pick them up until later, or various other things they're waiting for don't happen until later, and so they don't end up leaving the bed until 6 p.m. And of course, on the other side of that occupied bed upstairs is someone downstairs in the ED who's boarding and waiting for that bed. So a discharge lounge is just a place in the hospital where patients can go to wait, whether that's for rides or medications or whatever, without occupying their bed. And in this case, you can see that if we move patient 1 who's discharged but just waiting for a ride, if we move that patient over to the discharge lounge, it allows us to get the green patient who's boarding in the ED upstairs, and then allows us to use that room or that bed to see a new patient in the emergency department. This graphic is just to show all the points of intervention to get admitted patients upstairs from the ED faster. So point G represents having a discharge lounge, and that frees up that inpatient room faster for the next patient. Things like getting the inpatient room cleaned more quickly between patients, that would be point C. That would allow you to transport patients up from the ED faster as well. It's worth noting that a lot of these improvements, like cleaning the rooms faster between patients, are going to shave minutes or maybe in some cases hours off of ED boarding time. Whereas point D is where you might actually be able to reduce the total number of overnights that inpatients spend in the hospital by making sure that they're really making good use of every hour that they're spending in the hospital. So these are interventions related to expediting diagnosis, reducing delays in inpatient imaging or procedures. Now let's turn our attention to inpatient hallway boarding. We'll do another deep dive into this intervention. And the concept behind inpatient hallway boarding is simple, and it's very similar to the concept of the discharge lounge. That's why the graphic looks so similar. You're opening up some new space that ultimately allows ED patients to move out of the ED faster. So in this example, once again, in the top row, our green patient is admitted and she's boarding in the ED. She's using up an ED beds, meaning we can't see a new patient in the ED. If, however, we activate an inpatient hallway boarding program, we can now move that green patient up to a hallway space on the floor, which frees up her ED bed for us to see a new patient in the ED. So that's the basic concept. When you hear about inpatient hallway boarding, you might have a couple questions about the whole idea. First, is it safe? And then second, how do you actually execute a program like this successfully? There are a couple studies, and this is one of them, that reports on people's actual experience with safety when it comes to implementing these inpatient hallway boarding programs. So this is a study that came out of Stanford where they implemented boarding in what they call alternative care areas, which includes inpatient hallways. This was a retrospective cohort study where they looked at the periods before implementation, during the transition period, and after implementation of this alternative care area boarding program. From a safety standpoint, the results were quite favorable. They found patients who had been placed in alternative care areas like inpatient hallways actually had a decreased risk of transfer to the ICU and decreased rates of hospital-acquired infections relative to patients who went to a traditional inpatient room right away. Okay, so we talked about safety, but an equally interesting question is, how do you implement a program like inpatient hallway boarding? It's not easy to come to consensus with all the stakeholders involved in rolling this out, and it's the stakeholders largely other than those in the ED. So inpatient nursing, bed management, patient placement. Are there work rules or even cultural barriers that have to be addressed to persuade people to understand the value of reducing ED crowding through this particular mechanism? And so you can imagine, depending on the hospital and teams involved, the utilization and success of inpatient hallway boarding could vary dramatically. So at Stanford, they seem to have a fairly successful implementation of inpatient hallway boarding. They started, of course, having 0 patients per month board in inpatient hallways before the program was rolled out. But by the third winter of this program, they were sending, in some cases, over 100 patients a month to these alternative care boarding areas. So how did they do it? Well, here's what Shen has to say about it. He's the Vice Chair of Clinical Operations and Quality for the Stanford Department of Emergency Medicine. He's also the senior author of the paper we just looked at. And according to him, it's, of course, not possible to implement a program like this with the willpower of the ED alone, but rather Stanford assembled this hospital-wide patient flow team, which included senior leadership that met daily to review capacity issues, including crowding, and they discussed multiple interventions, so including but not limited to the inpatient hallway boarding program, and monitored their implementation using data. And that's a very poetic statement in some ways from Sam, because it so happens that all the elements he mentions are exactly what these authors found in their 2017 Annals of Emergency Medicine article, where they tried to determine what factors differentiated high-performing from low-performing hospitals when it comes to ED crowding. So in this work, the authors looked at hospitals in the top 5% and bottom 5% of CMS case mix adjusted ED boarding times. And they talked to leaders at 4 high-performing hospitals, 4 low-performing hospitals, and 4 hospitals that demonstrated significant improvement in ED boarding. And what they found, as it says on our headline here, is that specific organizational characteristics, not specific interventions, were associated with EDs that demonstrated lower crowding and boarding. These organizational characteristics are very consistent with the Stanford experience as Sam described it. So involvement of senior executives, not just at the outset of an idea, but in the daily management of its implementation and continuous improvement. Another element was having hospital-wide strategies, not just one intervention, but many interventions addressing all the major root causes of ED crowding. And then finally using data, both at the system level and to provide feedback to individual caregivers or team members to ensure that interventions are executed as intended. Finally, let's take a look at interventions related to hospital-wide coordination and economic incentives. So first, it's recognized that ED crowding is a hospital-wide problem, and so it should have a hospital-wide solution. As discussed throughout these modules, ED boarding, which occurs due to access block or inpatient bed unavailability, is a major cause of crowding. Inpatient bed capacity and utilization isn't controlled by the ED, it's controlled by the hospital. And for that reason, optimizing inpatient bed coordination requires hospital-wide efforts. That's where capacity command centers come in, which we'll discuss in a moment. And then second, we discussed this in Module 2, but current payment systems may incentivize many hospitals to prioritize higher paying elective admissions over ED admissions for inpatient beds, which guarantees ED boarding. You can refer to Module 2 for a more robust discussion on that. For now, let's take a look at capacity command centers. So here's a photo of the Capacity Command Center at Johns Hopkins Medicine. What is a command center? Well, capacity command centers are an emerging intervention. They're based on the same concept as command centers used in airlines, the military, and many hospitals are deploying them. Command centers have recently been defined as physical units that permanently co-locate interdisciplinary teams, and these interdisciplinary teams use real-time data to manage at least two processes related to patient flow. What kinds of processes are managed in command centers? Well, this review of 5 command centers found that teams responsible for interhospital transfers, patient transport, environmental services, bed management, those are the functions that are most commonly co-located in these centers. So what's the proposed mechanism behind how these capacity command centers work? Well, as we discussed, putting interdisciplinary teams together with real-time data instead of having them siloed is thought to improve decision-making speed and quality. And on the right side of the chart, you can see that in connection with actually getting the people and data together, which can be a massive undertaking in itself, health systems might also make other supporting changes. So they might begin to change the standard processes behind admissions or scheduling elective surgeries, or they might even dedicate an entire organizational function to capacity management. So in combination, all these changes drive the observed improvements in patient flow, like reduced ED boarding. And it's worth noting that the peer-reviewed evidence for capacity command centers is fairly limited at this point, but it's generally positive. And particularly relevant to this talk, most centers do report reduced ED boarding after implementation of capacity command centers. So we've talked about a lot in this module. Let's quickly summarize. In this module, we took a deep dive into 4 specific interventions. We looked at provider and triage as a potential mechanism to improve ED throughput. We looked at the discharge lounge and inpatient hallway boarding as potential mechanisms to improve output. And we looked at the capacity command center as a potential mechanism to improve hospital-wide coordination. And of course, there's a reason we emphasize the word potential in this slide is to once again reiterate the point that the root causes of crowding, whether they're related to input, throughput, output, or economic factors, vary by hospital. So if you're trying to solve ED crowding in your ED, the first step is to identify and quantify the root causes of crowding in your individual ED before figuring out what the solutions are. A3 problem solving is a widely recognized process. You're probably familiar with it, and you can use it to identify, quantify, and design countermeasures to the root causes of crowding in your ED. So overall, we discussed 4 categories of drivers for ED crowding: input, throughput, output, and hospital-wide factors, along with interventions to target each of those categories. We also discussed the importance of using A3 problem solving or other systematic approaches to identify local root causes to ED crowding and selecting those interventions that actually address those root causes. So that was Module 3. For a review on the definition of crowding and its causes, feel free to refer back to Modules 1 and 2. Thanks for joining us.